So I'm sharing my screen. Can you see this?
Yes.
Okay, please go ahead.
Okay. Yeah. Good evening, everybody. Yeah. So let's discuss about post-operative surgical patient. It's more of a clinical presentation rather than you've done with all physiology. Now we are moving to clinical setup, right? Okay. So start with first slide. Yeah. First slide. Yeah, so this is about post-operative surgical patient. So this actually it means the post-operative care of the surgical patient. So always, most of the patients are assessed pre-operatively for elective cases mostly. So this kind of not like emergency. So the elective patients who are assessed and those at high risk should be assessed and seen in the pre-assessment clinic. And risk stratification and mortality risk should be assessed, right? So depending on the scoring system that you are aware of, that is score, sort score, and some other scoring system. There are some other scoring system as well. Cardiac risk stratification for least revised cardiac index also. And this is done because to decide the where will be the patient going in the post-operative period. Okay, so this post-operative period is critical, right? So this high-risk patient should be monitored closely and assessed closely in any deterioration in clinical condition. And so this the in this juncture, I should mention about the levels of care as well. So there are levels of care, which is level 0, level 1 is ward-based care. Those patients monitored in a ward setup. So that is closely monitored and is with the monitoring of vital signs. And if they are in deterioration of a clinical deterioration, they will be escalated to the level 2 and level 3 care. So level 2 in that sense, it means HDU, high dependency care or enhanced care unit. So those patients will be going to those level 2 care. And we have this level 3 care, that is intensive care unit. So the most high risk patients who are assessed preoperatively, so it's decided preoperatively to send those patients to the level 3 care in the ICU. So the main aim of postoperative care is to detect the clinical deterioration early and track and trigger early, right? It is done by using early warning system, early warning score, national early warning score that is used widely in UK to identify deteriorating patients early. It provides a national standard for assessing and monitoring and tracking acutely and critically ill patients. I think you are all aware of this scoring system. Can we go to the next slide? So this has six physiological parameters. In the next slide, I have shared the photo that you are aware of. Always you are using that news to scoring. So in the next slide, yeah. So here we have all these six parameters: airway, breathing, respiratory rate, airway, this SpO2 scale 1 and 2, and C blood pressures, systolic blood pressure mainly, and the pulse rate, and the conscious level and temperature. So you are so these all parameters should be monitored, and the basic idea of monitoring is to escalate treatment in need of emergency or in the patient of clinical deterioration, and the frequency of monitoring should be increased according to the new score, right? So this usually the new score, if it's 0, so the patient is stable, and it should be like monitored a minimum 12 hourly, and it's anyway it should be continued, the monitoring should be continued in the ward. So it's done in the bedside, okay? So the total score is like 1 to 4. That means you have a minimum of 4 to 6 hourly monitoring. And 3 in single parameter, minimum we should have 1 hourly monitoring. And the registered nurse who are looking after that patient should inform the medical team and decide whether frequency of monitoring should be increased or not. And if the single parameter 3 in single parameter, and stay in that slide, so just want to mention on 1 or 2 points. So 5 or more urgent responses, so increased frequency monitoring of minimum 1 hourly to total score of 7 or more. That means emergency response is indicated, and there should be a continuous monitoring of vital signs every 15 minutes, and that should be escalated to the appropriate team. The med calls and the critical care outreach team will attend that patient, right, for immediate attention. So this is the importance of NILS scores. Usually it's done in the wards. We have the different monitoring, also the monitoring charts here. So we can continuously, we are monitoring this patient in ITU. So this NILS score is very useful. Okay. So in the next slide. So we can observe signs of hemorrhage in this with this chart. We can detect early deterioration because of hemorrhage or shock or sepsis or the effects of analgesia on anesthetic. So if the deteriorating patient is detected, then it should be appropriately uh, escalated to the appropriate health professional using this S-bar tool. I think you all are familiar with that. In the ward setup, they used to have the sticker with S-bar tool, situation, background, and assessment and recommendation that you need to document everything, right? So this is so done usually in wards here, right? So this is very useful to detect the signs early in the post-operative period. Okay, the next slide. So when it is coming to ITU care, level 3 care, mostly I'm going to discuss some aspects of post-operative care in ICU. So when a patient coming from theater, so after surgery, so there should be effective handling. So as all the SHOs are here and so listening. So when a patient comes from the theater, there should be effective handing over from theater staff to the ITU team, right? So you need to have for to continuity of care. You should need to have an effective handing over regarding the patient's name, age, relevant past medical history, allergies, and intolerance. Is there any problem in the past, or what are the medications, allergy, and details of anesthesia. So duration of anesthesia and what's the procedure it has been done, the surgical finding, and is there any the anesthetic problems or complications intraoperatively, whether they had hypotension and they have had blood loss or fluid replacement done or the blood products done, is as any ABGs or blood gases done or whatever. So you need to assess everything regarding this anesthetic and during this anesthetic um, time, right? And it's must to ask about analgesia given during surgery and next. Uh, and because the last dose, there should be a completed chart for required post-op analgesia, antiemetics, and IV fluids and other relevant drugs. If there's nothing, so you have to ask specifically at the last dose at what time it was given, for because it's useful to give the pain relief, and you can give optimum analgesia for the patient. So mainly the opioids, the last dose and what time and how much it was given. So it's very easy to manage, right? So there should be a multimodal analgesic technique for the patient to be benefited. So details of the drains, and so they are all the laparotomy surgery, abdominal surgery patients, all with sometimes with all multiple drains. You need to know. Sometimes nursing officers all aware, but we don't know, right? What's going on with those drains? One is nephrostomy, one is abdominal, one is pelvic, whatever. So you have to know about the site and how much is it draining. Is it what type of drain is it, and the site location and the importance of keeping the drain, and the wound site, and what is going on with that. And then you should ask from the surgical team where the patient can eat and drink. And so when the patient having had abdominal surgery, and if there's any contraindication, to start feeding early, so that we need to know as a doctor who is managing a patient post-operatively. And the baseline vital signs and observation should be it should be documented in the chart, so that should be noted. And there should be so you ask specifically for specific post-operative plan, is there any so some patients, they need a deep sedation to be kept, and sometimes some patients need paralysis. So depending on the different types of surgery, he have here most of them have abdominal surgeries mainly, but in other ICUs, neurosurgery or cardiac or the pediatric, or sometimes the abdominal surgeries, major abdominal surgeries, we go for some deep sedation to keep the patient sedated. And or tracheoplasty or something, we keep deeply sedated. So those kind of specific post-operative plan, and sometimes they may go for relook laparotomy. So you have to make sure if there's any specific post-operative plan. And yeah, so next slide. So mainly when the patient comes to ICU, post-operatively patient should be evaluated thoroughly with detailed assessment of medical history, examination, and detailed assessment of drugs which he is already on, and so which helps in the management in and good for the good outcome. And mainly the recovery from anesthesia, I'll discuss not deeply. I'm going to discuss about post-op pain relief and mainly on hemorrhagic shock. This is just I'm going through quickly. Recovery from anesthesia, so that need to be assessed to the suitability for extubation. If the patient coming with the tube, so you need to know how can we assess the suitability of extubation and the post-operative. So how long we have to continue the sedation, when to stop the sedation. So this all depends on the patient's nature of operation. And then the post-operative care, I'm going to discuss about that later. So venous thromboembolism prophylaxis, all this coming under ICU, mainly under ICU patients care. Usually in the ward also it does. And mainly the stoma care. And other slide, the next one, stress ulcer prophylaxis, as that you all know, I don't need to mention about that. So stress related mucosal disease, which occurs in patients mainly with head injuries, and the patients who are in ITU, or patients or burns, or mainly so patient, if the trauma occurs of the surgical stress, they have this stress ulcers, so we have to have prophylaxis. So make sure you check each and every patient that is done right. And yeah, and you know the drugs, I don't need to go into details. And nutrition, I'll just go through a little bit later. And management of blood glucose, that depends all the patients who are on diabetes, or the patients may have problem with hyperglycemia, or the uncontrolled blood sugar, that you need to control. And you need to monitor closely. So that's all. Mainly you check glucose because it impairs wound healing. It causes stress related problems, and it affects the post-operative outcome. Okay, that's the main reason. And optimizing wound healing, that's all that you do giving good nutrition, optimizing the blood glucose, and prevent the surgical site infection. Thereby, you optimize wound healing and early mobilization, and those management should come under this, right? And management of agitation and delirium. The patient, if the patient mainly in ITU, it's even the ITU stay itself cause agitation and delirium. There are a lot of causes. I'm not going into details, but it should be assessed in all kind of patients who are staying for long time, and not long time, even 1 or 2 days. You should assessment with CAM-ICU score. Maybe you all may be aware, right? So that should be assessed, and you should detect early and treat early. So, okay, that's a different topic. Anyway, somebody will present later. I don't know. It's okay. So move on to next slide. So mainly, as we have discussed this cardiovascular physiology, you all you are now clear about this hemorrhage and the hypovolemic shock. I need to tell more about this because most of the patients' perioperative periods are on the risk of major bleeding or like bleeding. So during and after surgery, which results in increased mortality and morbidity. So what do you think? What are the principal causes for this perioperative bleeding? As you all know, maybe the patients may be having pre-existing undetected bleeding disorder, or the nature of operation itself, or the vascular case, or the major difficult case, or the patients with the additions, they have done major tissue handling, so it might ooze. And so depending on the nature of operation itself, it is a cause. And maybe maybe because of acquired coagulation abnormalities, commonly this is secondary to hemorrhage and hemodilution. And next slide. Or maybe acquired platelet dysfunctions. The next slide. Acquired platelet dysfunction, coagulation factor consumption in extracorporeal circuit. That means that you use bypass machines. That is, so for CAB, cardiopulmonary bypass operation. So in that you get coagulation factor consumption, and it leads to coagulopathy, and patient might bleed. So it's all concerned for those kind of, mainly on this kind of patients. And there will be an activation of fibrinolytic and fibrinolytic and inflammatory pathways, which leads to coagulopathy. Mainly these patients are patients from coming from the theater is a high in a cold environment. They are more prone to get hypothermia if it is not managed properly, which leads to hypothermia and acidosis, more contributors for the coagulopathy of hemorrhagic shock. So these issues, these causes should be addressed each and every patient if it starts bleeding, or if you think it's so you have this monitoring, as I already told. So this hemorrhage or the bleeding should be detected early. For that only we have this monitoring system. That's the main aim of discussing all these post issues and topic, right? And the next slide. So mainly, if the patient was on oral anticoagulants pre-operatively, we anyway stop. But sometimes patient may have perioperatively, patient may have increased bleeding tendencies, warfarin, dabigatran, and rivaroxaban, apixaban, and platelet inhibitors such as clopidogrel, prasugrel, or ticagrelor. So those patient was on drugs, those are kind of increased tendency to bleed. And next slide. Those causes you should be aware of when you detect a patient with ear bleeding. So you should think of all these causes that should be sorted out, each and every cause. So just think about all the causes. So let's discuss about something about pathophysiology. it's common pathophysiology for trauma and surgical stress. So when you get a direct injury as a surgical incision, surgical handling, so you get a cellular injury, and then there's a cellular distress that releases inflammatory mediators and the toxins, so which leads to it activates the fibrinolytic pathway, which leads to coagulopathy, and also cellular distress, which causes apoptosis or the necrosis, so ultimately which leads to the organ dysfunction. And the direct trauma and the direct vessel damage causes blood loss, which ultimately leads to the ischemia of the cells, which also leads to coagulopathy. It's in a cycle. So ultimately we get organ failure and multi-organ failure, and ultimately we get the patient starts bleeding and ultimately ending up in another organ failure. Patient will result in acute kidney injury and acute hypovolemic shock, and patient go into hypoperfusion. Then other organs also will fail. Hypoperfusion, liver functions, so it will be elevated, and acute liver injury. So ultimately, this is, or if you are missing any simple or like minor bleeding, it will anyway, if it will drastically affect the patient's outcome. Okay, and next one. So you are aware about this classification of hemorrhagic shock. So this ranges from class 1 to class 4. This class 1, as you know, less than 750 ml of blood loss. And so a class 4 means that's more than 2 liters of blood in between class 2 and class 3. So as you have studied already and discussed already, they are always the physiology is the activated. So our physiological mechanisms are activated when the bleeding starts. The hypovolemia, so all baroreceptors are stimulated, and you get a high heart rate, tachycardia, blood pressure will drop, and then you get a tachycardia. Then it induces chemoreceptors, and the respiratory center you get a tachypnea as well. And signs of hypoperfusion will be result with a reduced urine output, reduced capillary filling, and all. So, class 1 mainly it's you can't detect a patient if you are not closely observing a patient continuously, because the parameters are well maintained. Heart rate is also normal, blood pressure normal, respiratory rate within the normal range, urine output is maintaining, but it's patient has lost 750 ml of blood. So this is the time that you detect the patient early, depending on your scoring on the clinical bedside assessment, concealed hemorrhage. And class 2 and 3, this class 2 is actually a compensated phase with tachycardia, when blood pressure is maintained with, as you, the Malik, no? Yeah, he discussed about this compensatory mechanism, tachycardia. So, patient will be having only mild tachypnea and the tachycardia. Blood pressure is maintained. So we are misled and we are misdirected. So this class 2. So urine output starts dropping. Still, we may have a chance to miss this patient. And class 3 is all the decompensated starting of decompensated phase. Patient's blood pressure will drop, tachycardic, patient will be tachycardic and tachypnic and reduce urine output. In this stage only, always all the most probably all we detect cases in class 3 sometimes. So that's not acceptable, right? And class 4, anyway, that's a severe hemorrhage with 2 liters of blood loss with more than 40% of blood volume. So everything is, patient is now in deteriorating, patient is going to collapse now. So at this stage, anyway, if a sudden bleed to more than 2000 ml or it's a class 4 hemorrhage, it's you should alert. So that's, you all know, so it's a major hemorrhage, you should activate major protocol activation, massive transfusion protocol. Even before that you should, but this is maybe it's a sudden bleed. Okay, then next you can go to the next one. Okay, next slide. please. Amaya. Okay. So, how do you detect this patient and bedside, in addition to your clinical assessment and the monitoring? So you can do a blood gas. If you think he's hypoperfusion, just do a blood gas and see whether his hemoglobin, hematocrit, and hemoglobin and the cellular hypoperfusion indicators, lactate values, and base deficit. When the patient's increasing lactate levels is getting acidosis, so just think of cellular hypoperfusion because of hypovolemia. So you can get the hemoglobin values as well here. So you can, it's easy bedside test to assess early. And there's as you are aware about point of care testing. Yes, so that is rotem, rotem, rotational thromboelastography, and the platelet function assays. This actually it is done in some hospital they have in ITU, and some theaters they have, but so you can send to the blood bank or the hematology lab to get it done. That's from this testing, you can assess the assessment of specific detailed assessment of coagulation assay, and you can target the specific therapy for hemostasis. So you can treat the patient specifically with the results. And the lab values, you can anyway you all sorry. So full blood count, hemoglobin platelet counts, and the hematocrit levels, fibrinogen, INR coagulation profile, everything. So these are investigations that you do, and other investigations to find out where's the bleeding is. So you used to do. You have, I think, our ICU. You have several experiences with patients with bleeding. So they all assess, and then you detect. So you escalate the problem to the consultant or the senior. Then you need to assess the patient, and you need to detect the source of bleeding. Here you need a CT scan, urgent CT scan to find out the site of bleeding, and need of maybe radiological embolization in patients in a suitable patient, stable suitable patient, rather than operating the patient, right? Yeah, next slide, please. So the management mainly, yeah, I said it should be a cooperation and the teamwork. It should be communicate. Always call for help. Always call for help as your doctor alone. Always call for help, and there should be a good management. There should be a good cooperation and communication between all the team members, anesthetist, surgeon, hematologist, blood bank staff, and theater assistant. So it's emergency. Okay, so the management goals is to achieve the hemostasis early, achieve the hemostasis by and restoration of blood volume and the circulating volume and blood volume replacement. Next slide. Then next slide, please. And that is done with fast, efficient initial management will reduce overall mortality and morbidity. So you always assess ABCD approach. Always otherwise you will miss things, right? So ABCDE approach, taking particular care to ensure whether adequate IV access and rapid fluid resuscitation immediately, mainly with the blood and blood products, depending on your bedside investigations and the throat findings. So not to dilute further, so you need to replace with blood and blood products. And and at the same time, it's all simultaneously you should do while the resuscitation is going on. You should read the operation. That's why I said it's an effective takeover, and read operation notes where the surgery is and the location, wounds and drains and areas of importance. That's why. So if we know the stuff, then we can manage quickly. And the direct pressure should be applied to the bleeding site if it is visible site or the upper extremities. And urgent senior surgical review should be sought, and appropriate imaging is arranged in order to ascertain the level of bleeding. Yes. Next slide, please. So urgent, as I told you, urgent blood transfusion should be considered. And if it's a massive hemorrhage, a major hemorrhage, it should be a massive transfusion protocol should be activated immediately. And here we have the setup like major hemorrhage call, so the always call for help. So everybody comes in, and there should be a teamwork. So everything is for your patient's good outcome. So upon the senior with the senior review, it may be appropriate to reoperate the patient for further hemostasis, or maybe we can wait until the patient, so if the patient is stable and mild bleeding, the senior is happy, but there should be a close monitoring anyway, always, but make sure you should not miss any major life-threatening issue. Okay. Next slide, please. So this all about post-operative hemorrhage. I think this is clinical. Only I mentioned about these clinical issues. If I miss anything, the last you can ask me any questions, and let's discuss about post-operative pain. As you all know, it's a pain relief. We can give through various modes of analgesic, various routes of analgesia. Intravenous, intramuscular, oral opioids, and other mild analgesic and moderate analgesics at the ladder. So we can provide a multimodal analgesic in the postoperative period as per patient control analgesia. And we can use non-steroidal anti-inflammatory drugs and paracetamol, and mainly the strong or mild dose to moderate or severe strong opioids. That would do better in the post-operative period in ITU setup and the HDU setup. And the main analgesia, this effective one is epidural analgesia and local anesthetic blocks. Even if it is given, usually it should be given in the theater, but sometimes we do in ITU also these blocks. Post-operative blocks, mainly the trauma patient or pre-operatively block patient, main for the trauma orthopedic surgeries. And always, most of the time, it's done in the theaters, local anesthetic blocks, right? So those that relieve the post-operative pain better. So let's discuss about just a revision about epidural analgesia. Next slide, please. What do you know about epidural analgesia? Yeah, it is an administration of a local anesthetic with or without opioid, the addition of fentanyl into the epidural space. So epidural space, which extends from foramen magnum to the sacrococcygeal ligament, it's a slender space. So it contains loose areolar tissue and the nerve fibers, sympathetic and motor sensory fibers. It travels through that, and when the placement of epidural catheter, which can be anywhere else or along the lumbar, thoracic, or spinal column, depending on the site and nature of operation. So you can decide whether it is decided it should be in the intraoperative period. So they should insert this epidural depending on the site of surgery and extent of surgery. So it is continued in the postoperative period in ICU setup. Next slide, please. Next slide, please. Okay, so mainly this is an effective mode of analgesia. Why is that than the other modes of analgesia? It gives a best pain relief, because it has some other benefits as well. In addition to the pain relief, analgesia at rest and movement, and it actually dilates. I'll discuss about the mechanism. It dilates the vessels by blocking the sympathetic fibers, so the tone will be relaxed. So they will have a vasodilatation. So it reduces the thromboembolic complications as well. And also it improves pain relief, and patient can breathe nicely. So they have reduced pulmonary complications and improve respiratory function. It leads to early mobility and early recovery. and it helps in reducing cardiovascular complications such as like chest pain, post-operative maybe vasoconstriction is reduced, so it relieves and helps in cardiovascular system as well, and reduce the incidence of ILS. So it paralytic ILS incidence also will reduce, and also we can reduce the systemic opioids, and you can have a spare opioid sparing effects, so we can avoid opioid side effects, right? And NSAIDs as well, and it reduces the surgical stress response. It reduces negative nitrogen balance and fatigue. So this more benefits than the other modes of analgesia, and it is easy to continue in the post-operative period. It will stay for 3 to at least 48 hours to 72 hours. So you can so next slide please. So you can you can top up with um, uh, some other modes of analgesia when you are coming out of this epidural. So when you remove the epidural. So when it's contraindication, you should know. That's why I have put this, because it's always inserted in the post-surgical patient, always inserted in the theaters. But you should know about this contraindication. Patient can refuse, so that's an absolute contraindication. Or the infection at the puncture site, or the coagulopathy, allergies to the local anesthetics, or systemic infections, raised intracranial pressure, and the spinal abnormalities, deformities that make the catheter placement difficult. So all these are the contraindications. Just to know about this for your knowledge. And the next slide. Next slide, please. Yeah, so the before that, previous. Okay, yeah, how does this epidural work? Which is the analgesia is given in this epidural space. So it will block the nerves roots lying outside the dura mater, epidural. So it's by using a local anesthetic solution. So it blocks sensory nerves carrying the pain fibers, C fibers, and then AL delta fibers. So it and sympathetic nerves and the motor nerves which travels through that. So mainly it blocks the temperature fibers, and then later it depends on the myelination and the diameter of the fibers. The range of block depends on that. Um, okay, then first patient will get a the absence of cold sensation, and then pinprick sensation and the touch. But if it's the concentrated solution in the volume is used more, patient may get a motor block, right? And it can be administered by continuous infusion. First, when you put an epidural, you check with the test dose, and then you can continue with the continuous infusion or by bolus injection at the theater, and it should be continued in the post-operative period. So you should be very aware about this, whether it is working. So you should assess the patient properly if the patient is in continuous infusion, or the if any the block injection or the bolus injection. And so yeah, you can add on with adjuvants like clonidine or epinephrine. So you can the next slide, you can go it accent the quality is better. So next slide, I put Amaya, please next slide. Yeah, so when you add on the epinephrine, it mixture, it improves the pain relief and attenuates the sensory block regression and reduces plasma fentanyl concentration. So it's an advantage. So usually you are aware about these drugs. 0.1 to 5% of plain bupivacaine, 0.1 to 5% of plain bupivacaine plus fentanyl. So we have this bag of pre-filled bags. So you can use these drugs when the patient is getting systemic PCA or with the opioids. We can avoid this opioids or fentanyl in the epidural infusion. So always you should know about this, what's going on with the patient, whether he's on epidural opioids or not, right? And okay, the next slide, please. So, and you can give a patient control epidural analgesia with the background infusion, with the patient self-titration and the sparing of local anesthetic consumption. So this should be dependent on awake patient, cooperative patient, and it should not be sedated after general anesthesia. And okay, yeah. So move on. Yeah, as you all know, these patients should be monitored. These patients with epidural should be monitored in level 3 care or level, usually level 3 care in the ITU setup. The trained nurses, in order to detect the early signs of problems, those are like life-threatening or dangerous problems that should be addressed. So epidural hematoma, as you sometimes you'd have heard about it, abscess and immediate life-threatening events such as respiratory or cardiovascular depression because of the complications or catheter migration into subarachnoid space. So it can drop the blood pressure and patient can go into cardiac arrest as well. So you should be aware about these complications, and then usual commonly patient may have. So next slide, please. Yeah, may have. So okay, so I'll discuss about it. So a common thing when you commence an epidural, so vital signs should be monitored and the motor block should be recorded. Motor block signs should be recorded according to the Bromage scale. So vital signs monitoring every 10 minutes when you commence epidural in the ICU by the trained staff, that should be monitored every 10 minutes for 30 minutes, and then you half an hour for 1 hour, half minute, 30 minutes for 1 hour later. Then you can monitor hourly for 12 hours. Then you can, until discontinued, it should be monitors like 4 hourly if the patient is stable and when pain controlled, well controlled. When you give a top up, when you give a bolus, when you give, increase the rate of epidural infusion, again you should monitor for 10 minutes, for 30 minutes, 30 minutes for next hour, then resume the normal monitoring as prior to the top up. Okay. And yeah, so if you want to monitor the motor sensory block, it should be sorry, hourly for first 4 hours. So and 4 hourly thereafter. And as clinical need arises, if the patient complains, you should again check the motor block. Yeah. So and after top up the bolus dose, again you should monitor the motor block or whether the patient has got the sensory level and patient is relieved with pain. So you should monitor again the same thing for 10 minutes or 30 minutes and then resume prayer monitoring. Okay, so yeah, and there are instances that may occur like patchy block, and you may aware about those wordings. Patchy block, inadequate block, and inadequate analgesia. Patient may shout in pain, even the patients on epidural infusion. So those kind of troubleshooting issues should be you should be aware of. Sometimes the nursing officer, the nursing staff will document and let you know about those problems with epidural. Patient may have a patchy block, and you may continue the infusion, or you can increase the rate, and then you call the anesthetist or the senior person. And if the patient's having inadequate analgesia, anyway, you have to increase the infusion rate and see the response and you monitoring. And then after 1 hour, if it's not relieved, then you can review again and call your senior to get the issue sorted out. And if the patient's having a heavy motor block, and if the patient can't move the legs, like a spinal anesthetic, heavy dense block, it should be addressed immediately, because you first stop the if you have a doubt and if you think it's significant, so you just stop the infusion and then escalate your senior, and then you can watch for like 1 hour as to see whether it's it's getting relieved. If it is not, if it is persistent heavy motor block, you should address, and it should be investigated. So it can happen with all this. I told you this life-threatening dangerous complications may occur with epidural hematoma, epidural abscess. So patients fully block, persistent block. It should be decompressed early within 6 hours, I guess. Yeah, nerve conduction should be done, and it should be it should be done. MRI. I had a patient last on call. Patient had an abnormal sensation after spinal, but it's after like 4 days. But still, you have to worry about the issue, and we have done an urgent MRI to exclude any issues with hematoma or abscess following that spinal or epidural. Okay, then, yeah. Oh, Amia, what happened? Yeah. Yeah, yeah, um, yeah, you can share the screen widely. Okay, then as you all know, this all common complication, I can go quickly. Low blood pressure, respiratory depression, and already told itching and shivering, and that can be treated with histamines. So yeah, go to the next slide. So when we do remove epidural, we remove after 3 to 5 days, usually 72 hours. If it's epidural is not working or leaking, so you should be taking out the epidural. Before taking out, if it's not working, you should supplement with adequate analgesia, the modes of analgesia. Make sure. Okay, so and main issue in the ITU post-operative period, patient will be started on anticoagulants and epidural analgesia. So patient with the epidural catheter, we remember that patients with catheter, you prescribe anticoagulants. So the prophylactic dose of removal of epidural should be done after 12 hours of Thileepan as a prophylactic dose. And so when the next dose should be given after 4 hours, you should remember that. And left delta parent of treatment dose, you should wait for 24 hours to remove the catheter. And the next dose should be given after 4 hours. IV heparin, that should be given, removed um, after 4 hours. And next dose will be started after 4 hours. And the rivaroxaban with different 18 hours, you should wait after last dose, and 6 hours for next dose. Clopidogrel anyway, that's 7 days. So we are not any patients always, the surgical patient will not be on clopidogrel for 7 days. So, and post-op, if you want to start, you have to consult your consultant and hematologist to wait for 6 hours and then decide on starting clopidogrel. Yes. And okay, let's move on to the next slide. Okay, so that's all. This is the main I want to discuss about this epidural. Other than that, all the issues is all different topics. A vast topic. You can just discuss and finish my presentation. Nutrition, mainly the post-ops, as you all know, post-op surgical patients are exposed to major nutritional challenges. They have increased catabolic rate and demands of wound healing, increased inflammatory response, and abnormalities of bowel motility, anastomotic function, and swallowing issues, decreased immunity. So all those all issues coming under the nutritional challenges. And so there are ways of routes of nutrition, parenteral and enteral nutrition. In ICU patients, most of the patients should be assessed. All the patients should be assessed for early enteral feeding. If there's no not suitable to start early enteral feeding, if there's any contraindications to start enteral, we should start parenteral nutrition. So that's depending on the surgery and the nature of surgery. Okay, so enteral nutrition, if you start enteral nutrition, early enteral nutrition is always beneficial to maintain the gut integrity, and it increases the gut blood flow and stimulate the gut function, and it helps in early good outcome and early recovery of the patient. And yeah. Okay, so stomach care, I'm not going to do deep because we are not managing normally. It's a special care by a stoma nurse. I just want to mention one or two words. It varies in size and step. If the patient is coming with stoma, it's the ileostomy or the colostomy or the leukoendostoma, just make sure that you check at least. Stoma should be very shiny, wet, and red. If there's any issues with that, if there's any change or if normal is having high output, so you should be aware of this. That's I wanted to mention about this. And does not usually this stoma has no pain, no endings. So the and then the stoma nurses play a vital role in this patient care. So go to the next slide. They come, so always the stoma patients, colostomy patients are assessed by preoperatively assessed, and stoma care counseling has been done. Specialist teaching of stoma care during hospital admission is done, and it's educated to the healthcare professional as well. And they will give support in the community on discharge as well. They will follow the patient up. So these all nurse-led clinics in the hospitals, and they continue the follow-up. So those are that I just want to mention about this. So, okay, they're all. And okay, so just to move on, please. So there are potential problems just click on that. Next, just continue. Yeah. So there are the long term. Patient may have this stoma prolapse, stoma retraction, stoma necrosis, and stoma trauma, mucocutaneous separation. So those are some issues. Stoma stenosis. Those all we don't need to know much about it. And there are high output stoma. Maybe in the OITU setup, you may come across patients like this. So you should exclude short bowel obstruction. So you should rehydrate the patient well, and restrict oral hypotonic fluids. And its main aim is to rehydrate the patient. And they said to take loperamide high dose before food or drink, and maybe omeprazole will help. And you should monitor the sodium and magnesium concentration in the urine and the blood. Okay, and move on. And some nutrition advice you just give the patient as your ITU doctor. So you give the advice to the patient: eat regularly, the post-operative after discharge as well. Drink plenty of fluids to avoid blockages. Chew food well, and you ask the stoma nurse or dietitian to take the vitamins and the need of vitamins for the patient. And if they try a new food in small, they should try small quantities so they can make the adjustments of this complications or the high output or whatever. The patient should be able to eat a healthy diet, and antibiotics, fried foods, have caffeine, alcohol, spicy food may all increase the output. So to thicken the output, they say advise foods such as bread, potatoes, pasta, I don't know, bananas, root vegetables that should be taken by the patient for a good outcome. Okay, yeah. Okay, so this just mainly I considered on analgesia and hemorrhage. So these other topics will be discussed later, I guess. So my references are mainly from the BG article. That's all pathophysiology. I didn't mention more of it, only clinicals. And this is the second one is the article. And yeah, that's all. Thank you so much. If there's any questions, you can ask me or Ramya. Are you happy with that? Are you all clear?
Right. Thank you very much, Gowsiga. It was a very extensive topic. And sorry, in between, I kept my finger on the scroll and it kept on scrolling fast.
Yeah, that's okay. Yeah, I
Uh,
think, yeah, I have taken some